All right, good afternoon. I'm Kimberly Northrup from CE Central. I'd like to make a few announcements before we start. We have muted everyone's microphone. Please ask questions via the chat function. At the end of the talk, I will read as many of them as I can for Dr. Hesselson to answer. We will also display the Get Credit code now and at the end of the talk. Today, our speaker is Dr. Erin Hesselson. Dr. Hesselson earned an MD from New Jersey Medical School in Newark and completed a Harvard medical residency at Beth Israel Deaconess Medical Center in Boston. He completed fellowships in clinical cardiac electrophysiology and cardiology at Duke University Medical Center. He is certified by the American Board of Internal Medicine in internal medicine, cardiovascular disease, and clinical cardiac electrophysiology. Dr. Erin Hesselson has nearly 30 years of experience in the field of cardiac electrophysiology and brings his experience in complex cardiac ablation and device management of congestive heart failure to UK. Please welcome Dr. Hesselson.
Great, Dr. Northrup, thank you very much. And I really appreciate being invited to COVID Grand Rounds. I hope everybody is doing well within the scope of our current status. I'm going to talk about COVID-19, the electrophysiologist's perspective, and I have no financial disclosures to declare. In about the week and a half ago that I was asked to give Grand Rounds, I've now grown a great appreciation for how much information there is out there regarding COVID. And certainly this is rapidly evolving. There's a lot of observational data. So what I've tried to do as best I can is to distill down as much of this information in terms of accomplishing what I perceive to be today's objectives. And simply put, directly, how does the COVID-19 virus seem to affect the heart, and particularly as regards its arrhythmic potential? Certainly as well, we recognize that the arrhythmic potential is also potentially enhanced by the pharmaceutical management that we're bringing to bear. And when we reflect on both of these objectives, when all is said and done within the scope of COVID, there's really not a generous difference in terms of what we actually do to manage the situations. Rather, it's how within the scope of PPE and our equipment in terms of how we will take care of these issues. And you'll appreciate that as I get further on into the talk. Certainly, I'm not going to spend much time at the end there, but certainly I want to briefly talk about ethical dilemmas. And this is not just solely within my scope of practice, but certainly anybody who's practicing within this will feel these issues. But I will just touch the base on that of how we manage and or how we are not managing and what are we going to do as we hopefully will begin to open up. So any talk about COVID-19 would not be appropriate unless let's basically talk about how does the SARS virus get into the cell. And if you look on your screen on the left, there's typical spike proteins on the SARS virus. It's targeting human cells. It will attach via the angiotensin converting enzyme 2 receptor. And these receptors are expressed in multiple places in the body and very prominently in the lungs, the arteries, certainly the heart, the kidneys, and the intestines. And if we pan to the right of the screen, once the virus is into the cell, it will then cleave via atom 17, a metalloprotein that liberates the ACE2 inhibitor, and that's the mechanism of downregulation. It's really one of the concerns regarding how does the virus directly cause myocardial damage. Essentially, in this slide, we're looking at the activation of the renin-angiotensin system in terms of, if we look in the middle of the screen, there's the SARS virus. It's having a promotion effect of angiotensin 2 and certainly an inhibitory effect on the angiotensin converting enzyme 2. And the resultant effects of this are promotion of vasoconstriction, inflammation, fibrosis, other factors, hypertension. And again, it also as well inhibits our ability to use the proper angiotensin system to promote vasodilation, anti-fibrosis, proliferation, lowering of blood pressure. Certainly early on, I know there was some slight media sensation regarding the fact that we have patients on blood pressure medications such as our ACE inhibitors and our ARBs. And we see these on the screen, and particularly the concern was, well, if the ACE inhibitors have a promotion effect of ACE2, well, is that going to provide more receptors for the virus to attach to, and will those people do worse? Similarly, regarding the angiotensin receptor blockers, I'm going to give more on that shortly as we actually have data in that regard. But again, some of you may have heard about that in the media, and that was certainly not through any active trial. As I've alluded to, yes, certainly there's direct damage that will occur with the virus factors. But again, ultimately, what happens or what accumulates to cause heart damage, it's very multifactorial. So besides the direct viral damage, there's hypoxia with the dysfunction of the lungs, hypertension. There's just the storm of inflammatory response and cytokines. And again, these things can have direct damaging effects on the cardiac, on the heart, as well as causing issues with microvascular dysfunction, leading to heart failure. And all these, if you look at the lower right of the screen, all of these can promote arrhythmia. But this is an early example of a patient in China showing different manifestations of myocarditis. In the upper left panel A, we're looking at the CAT scan of the chest and the ground glass appearance you see of the lungs. And on B, the arrows, the green arrows, are pointing towards the EKG changes that occurred in this patient, being inversions. Panel C is the echocardiogram test showing the arrow left ventricular hypertrophy. And in D, it's an MRI scan of the heart, and the arrows are pointing to late gadolinium reenhancement, suggesting there's scar at the apex in the inferior wall. Now, in retrospect, my suspicion is this patient was taken care of very early on because they managed to get through a lot of the hospital system and the scanners and EKGs in order to get these tests done. So one, it's interesting that these findings occurred, but in the scope of what we now know and how highly contagious the virus is, I would find it surprising that we accumulate a significant amount more of data like this in the MRI and the CAT scan and echoes. What is the cardiovascular burden of the coronavirus currently? Now, these data come out of China, and what we're looking at on the screen there on the left is all of the confirmed COVID-19 cases, and it's broken down, but what are the comorbid conditions. And certainly in the brown, we see hypertension, the gray, cardiovascular disease, and certainly in the violet, no comorbid conditions. And on the right, what are the confirmed deaths and what is their comorbid conditions? Certainly we see approximately half of the data coming out of China, which they reported, involve patients with hypertension and cardiovascular disease. Certainly as well, I found it interesting in looking at this data that certainly confirmed deaths, about a quarter apparently reported have no comorbid conditions. Now, certainly my understanding of the more recent reads of our observational data is that the percentage of patients who have the disease and are complicated are more so. There is at least one comorbidity. In any event, again, this is evolving data. This is some of the initial data out of China. Certainly Italy has also been significantly affected by the pandemic. In this group, they try to take these factors that we've already discussed regarding all this violent storm of inflammation and direct effect of virus and collateral damage of the heart, and try to distill what observational data had been reported and comment on regarding lower right-hand quarter, what are the arrhythmic issues as a result of this myocardial conduction system damage. Certainly in distilling this information down, essentially they reported out, yes, there are tachyarrhythmias, yes, there are bradyarrhythmias, yes, there's increased QT interval drug induction, and yes, there's sudden cardiac death. But beyond that, in terms of trying to understand how we categorize each of these different arrhythmic issues, it's really hard. There's a lot of not reporting and separating out what has occurred with patients. Just a few days ago, the New England Journal This study was presented by a group prominently on patients out of North America, approximately 9,000 patients. Certainly there's some participation in Europe and Asia. And essentially what they wanted to look at is what is the mortality in COVID-19 and what are potential risk factors that we can put our fingers on and identify. And certainly one of the factors the study wanted to take a look at was, well, this whole question of ACE inhibitor and ARB, was there a significant issue with this? And again, we have to take this for what it is. This is observational data. This is not a randomized controlled study, but be that as it may, when we look at what in a multi-regression analysis came down to be significant, age of greater than 65 predicted mortality. Female sex was protected. Presence of coronary disease and congestive heart failure was arrhythmia in general. And again, they didn't break down what kinds of arrhythmias we're talking about, but certainly the arrhythmia showing up during the hospitalization, this was a predictor of not doing well. Certainly, back to that. COPD, receiving an ACE inhibitor fell very much to the left of the line of unity. So we grew some, at least some reassurance that no, people on ACE inhibitors do not, based upon this data. Similarly, the patients receiving the ARBs, it crosses the line of unity. Certainly people receiving statins as well, they seem to do more favorably. One of the earlier reports coming out of Wuhan, 138 hospitalized patients with the coronavirus. Certainly they did report on the incidence of arrhythmia within that small group, occurring in the circle there to see approximately 17%. Again, the study didn't necessarily categorize all the different types. I'll talk a little bit later about the more lethal report in that study. But certainly if you were sick enough to make it to the intensive care unit, there was a nearly 50% incidence of arrhythmia. And however, in reporting these data, it was unclear type. Again, one thing we should, not we should, but certainly understanding that's interesting about the study, there was a generous percentage of these patients who were already in the hospital for other reasons, and they got the coronavirus. And certainly there was a percentage of patients who ultimately were hospital workers. So I think some of these data occurred in the setting before we knew about the easy transmissibility of the disease. This is a paper about a paper. And what I mean by that is this. This is a group from Italy with some input from groups in New York. And taking that previous study I just talked about, and not writing an editorial per se, but essentially writing another paper that reported in circulation. And if you will, I guess, in reinterpreting some of the data. When they looked at the Chinese data and the 138 patients that were hospitalized with COVID-19, certainly arrhythmias represented a large population, complication after respiratory distress. And again, as I mentioned earlier, very highly prevalent intensive care unit. They did, however, drill down a little bit more to see that, yes, about 6% of all patients in the study had a malignant arrhythmia. And the thing, I think the point they really wanted to make with their analysis seemed to be the fact that there was this discontinuity or disjunction between report of arrhythmia and myocardial injury. Because when they looked at the patients who were in the intensive care unit, only about half of those who had arrhythmia actually had a significant elevation of their troponin. So the supposition was then, well, there must be some other cause, and that led them to postulate that, yes, could it be the actual treatments that were being brought to bear, whether it be the chloroquines or azithromycin. And so hence that was the logic behind their talk being mind the gap, and I'll explain a bit more about that when we talk about long QT and arrhythmia induction torsade. And as a result of their analysis, again, this is sort of a similar looking slide to what we've seen earlier, but really I want to focus down at the bottom. Again, they sort of separated out the production of arrhythmia into two factors. what is the on the left, what is the direct cause of myocardial injury, and certainly what is the likelihood, or what is the contribution of QT interval prolongation with the treatments that we're actually bringing to bear. So that being said, there are case studies coming out of multiple facilities that are talking about different actual arrhythmias. So here we're going to get into some manifestations. Again, we don't have a good feel for prevalence, but we do know that these can occur, and I hope to explain very shortly why we think these are occurring. From one patient coming out of Wuhan, and it's essentially we're showing the progression of what happens on EKG. So in the upper right, panel A, the patient's presentation, there was sinus tachycardia. They have a little bit of a first-degree block. And as their hospitalization progresses, panel B, we still see them in sinus tachycardia. We still see first-degree block, but we do see some evolution in the EKG. Now, the S wave was prominent in lead 1 earlier, T wave as well, but now we see an inverted T wave in lead 3. And if you remember some of our earlier medicine teaching, S1, Q3, T3, that was one of the buzz terms, if you will. Always for this person to have pulmonary embolism. Well, this patient was reported not to have a pulmonary embolism, but the postulation was that there were significant changes in the pulmonary dynamics via exterior compression or other hemodynamics that caused this sort of EKG manifestation to occur. That being said, it was found to be transient in that regard. Just as an aside for those of us thinking about pulmonary embolism, S1, Q3, T3 is not the most common manifestation of EKG in a person with actual pulmonary embolism. It's actually sinus tachycardia. And this is the same patient. And what we'll see is that the rhythm will change in panel C. All the arrows are pointing to the P waves. And we can see that there is a degree of dissociation between the QRS complexes, albeit there is some variability in the R-to-R intervals, suggesting that there is some degree of conduction getting antegrade from the atria, and thus suggesting that this is a Mobitz type block. Just below that, in the beginning of panel D, we do see that there seems to be a junctional escape, and there seems to be a complete dissociation between atrioventral, i.e., complete heart block. But as the patient progresses in their improvement by panel E, this is all spontaneously resolved. And so that leads me to talk about the picture in terms of what the researchers postulated was the reason for these EKG changes, hypoxia. Now, again, this is not specific to the COVID infection in terms of effects on the EKG. We in the electrophysiology service here certainly see very frequently we get consulted for patients with bradyarrhythmias, heart block, what have you. And one of the things that we look for is what is the comorbid condition going on? Are they hypoxic? Are they having sleep apnea? So again, these things are expected potentially to improve on their own as the proximate cause, in this case hypoxia, is managed. The paper showing the case studies of EKG changes, this is a second patient, not so much any arrhythmia concern, but certainly showing us other manifestations. What can happen on the EKG with a sick patient? In the upper left of the screen, panel A, we see the patient presenting arrhythmia to their hospitalization. It's sinus tachycardia. Lead V1, we see an RSR prime, so there's a right bundle branch block. Panel B, just below it, as the patient progresses in their illness and their hospitalization, we look down to the lower left, leads 2, 3, and AVF. My arrow, there we go. There's a little bit of degree of ST elevation going on. We do see, begin to see a hint of that in V3 and V4. And then again, as the patient progresses, they ultimately ended up on ECMO. We see these very, very significant changes occurring in EKG. These huge ST elevations in leads 2, 3, AVF. We even see a change in the QRS complexes in V1 through V3, essentially almost looking cued out like an anterior infarct. And by panel E, these changes become even significantly more prominent. And certainly the supposition was that perhaps fulminant myocarditis played a role. This patient wasn't apparently cathed to see whether or not there was any actual underlying coronary disease. But that being said, they suspected that the changes from the myocarditis itself occurred. Ultimately, this patient did show this on the final EKG representation here, ventricular tachycardia. It was a monomorphic ventricular tachycardia. I know it's hard to see the group a little bit. It's not terribly fast, about 150, but unfortunately, ultimately, this patient passed of the illness. Which leads me into how do we manage all of this? And as I alluded to earlier when we first started talking about my goals in terms of this talk, there's not a heck of a difference in terms of how we would go about taking care of these tachycardia and arrhythmias. Now, this is from a recent excerpt in CIRC, and talking about management, specifically the COVID-19. Again, in the yellow are highlighted are essentially the changes to the algorithms regarding this unstable patient cardiac arrest. The left showing V, VF, VT. We get to the yellow, we've donned our appropriate personal protection equipment, and certainly there's a statement there regarding prioritizing intubation. And those recommendations hold for either side of the screen, whether it be asystole PEA or VT-VF. We'll certainly notice on the right side of the screen, drug therapies, epinephrine, amiodarone, lidocaine. Again, from our basic teachings of ACLS and cardiac arrest, there should be no change in application of those drugs to their patients' particular arrest. Let's talk about a little bit about the potential treatment targets now. And certainly, I think you've had talks. It was early in April, talked about pharmaceutical management. And my purpose here is not to talk about pharmaceutical management and what has been the success or unsuccess of use of these medications. Suffice to say, I want to talk about the medication in the context of what effects can they have on the patient from an arrhythmic perspective. So when we look at how researchers are trying to figure out how to target COVID-19, we can look at many different facets of the virus and how it gets into the cell, et cetera. Certainly from the upper left, circle 1, fusion, monoclonal antibodies, sort of traditional antipancreatic types of drugs, camostat, namostat. Certainly, can we think about drugs that may affect the translation? Proteolysis, lopinavir, ritonavir at circle 3. Can we affect the translation of RNA application, the packaging? Certainly endocytosis as the virus is brought into the cell. Here we bring in anti-malarials, chloroquine and hydroxychloroquine. Where can they have their effects? Certainly, more recently, remdesivir, previously looked at for Ebola, and can this potentially have an effect, positive treatment for COVID-19? Certainly, in going through different reports, I came across this one as well, which I had not heard today, actually theorizing amiodarone as a treatment for COVID-19. And this comes out of the American Society of Cardiology. One thing that I learned was that amiodarone has an effect within the cell endosomes and lysosomes in terms of increasing their pH. And if we look at the circle at the upper right hand of the screen, this is sort of after the fact, the virus has entered the cell through the ACE2 receptor. So before the virus can release its genome, if you will, and hijack the DNA machinery of the host cell and replicate, apparently the change in pH from the amiodarone can prevent the virus from releasing its genome, and thereby could this be a potential target for preventing viral replication and certainly mitigation of the disease? At this point, I'm not aware of any literature suggesting that has been used, but again, in theory, this seems to be something that can pique our interest in whether or not it will be used well. It remains to be seen. Well, collateral effects from the drug. Again, obviously, I've alluded to this already, and this is an example of a patient's EKG. And I know, forgive me, it's a little blurry, but if we look at the QT interval, it's measuring over 600 milliseconds, and that is the concern. Are we causing harm to patients by bringing a drug to bear? I don't know how many of you are familiar with the Food and Drug Administration adverse event reporting system, and particularly as regards our potential candidates. I figured I would show you this chart here that goes through some of the more common things that we're seeing being used as potential treatments for COVID, and relating what is their potential risk for TDP, which is torsade de pointe. Certainly, we know that there is a risk through chloroquine and hydroxychloroquine, azithromycin, antibiotic as well, lopinavir, ritonavir, yes, anti-inflammatory agents or monoclonal antibodies. Apparently, no classification at the present. And again, at the bottom, miscellaneous agents such as camostat, no classification yet. And certainly famotidine, or a lot of familiar know as Pepsid. Again, our very sick patient won't be unusual to see these patients red stress ulceration of the stomach. Patients will be on this. Certainly, it seems to be conditional, and primarily the risk of torsade seems to be driven by other comorbid issues such as low potassium, impaired clearance of the drug from the body, because by itself, the review literature shows that the risk seems to be low in terms of provocation of torsade de pointe. Let me spend a little brief time about azithromycin. Certainly, I think there's some inclination that we may be moving away from using this as a concomitant treatment, at least a multi-drug treatment when coupled with the antimalarials. But I think it deserves knowing that azithromycin is not without its risks by itself. And this is from a report in the New England Journal from 2012. And what I'm showing you is what was the risk of a cardiovascular death or death from any cause occurring as a result of patients being treated for whatever condition with azithromycin. And essentially, if we look at the graph on the left and we look at the hash dotted line, the investigators broke this down into the first 5 days of treatment versus the second 5 days of treatment. When compared to not receiving the antibiotic, they saw an increased risk of cardiovascular death or death from any cause. Now, the authors didn't dive too deeply into speculation of well, within the cardiovascular death, what was the cause? This was observational data coming out of a Medicare database in Tennessee, so they weren't able to separate out how much was this arrhythmic, how much might have been something else. But certainly there was a little bit of pause for concern with you using azithromycin. Certainly now, if we couple that with the antimalarials, that might be more concern. So let me switch gears a little bit, and I'm going to focus a little bit on the antimalarials. We certainly need to be concerned that there is a potential for significant drug-drug interaction with chloroquine and hydroxychloroquine. And these interactions can occur in terms of accumulating risk for torsade de pointe. The hydroxychloroquine, chloroquine can affect the rapid potassium channel in terms of emitting, if you will, potassium during phase 3 in the repolarization. So any drugs that also can enhance prolongation repolarization may have added risk. Certainly, on the right, if we think about the pharmacokinetics of these drugs, they can affect the P-glycoprotein system. So certainly our patients who may have had an organ transplant, maybe on cyclosporin, those patients who may be on digoxin, again, where those drugs are affected by the P-glycoprotein transport system, we need to be cognizant that there may be an interaction there. As regards the P450 system, the chloroquines can affect CYP2D6, ritonavir, lopinavir, CYP3A4. So these, again, these interactions would be antihistamine drugs, cimetine, other drugs, clinical antifungals, antibiotics. We need to be aware that these interactions can occur, and we need to remain vigilant to make sure that we are not putting too many of these once. In that regard, there was a group out of New York that looked at the risk of QT interval prolongation associated with the concomitant use of hydroxychloroquine with azithromycin in admitted patients. The study was of 90 patients. And when all was said and done in terms of their goal of looking at QTc peak being greater than 500 milliseconds, what factors came out of their regression analysis in terms of prediction of who would reach that endpoint? If those were patients who were on a concomitant loop diuretic, that was risk. And we would think about that, the basic function of loop diuretic. We could lose potassium. Again, pointing out that yes, hypokalemia is not our friend in this regard. But certainly as well, baseline QTc greater than 450, that suggested that then, yes, you were more likely to have a segment coagulation above 500 milliseconds or QT, if you started out there. And certainly those patients who had SIRS criterion, they just barely met clinical significance in that regard. Let's talk a little bit mechanistically about Torsade de Pointes and how it comes about. Because again, I think it's useful. Again, it's nothing different regards the SARS virus, but certainly our antenna are heightened as to the possibility of this happening, given these different drugs that we're bringing to bear. So upper left of the cartoon, EADs will fall early after depolarizations. This is the mechanism of how one may initiate Torsade de Pointes. Again, reminding ourselves that essentially I'm circling around the IKR, the rapid potassium channel, which is modulated by hERG protein channels. That's where a lot of the drugs can have their effect in terms of their provocation or increased likelihood of causing torsade. In the middle, we're looking at the action potential, and that's the normal in black. As we give drugs that prolong repolarization, the action potential becomes more like the green line. And then what happens during phase 3 of the action potential in the blue, the EAD, the after depolarization can occur. And this certainly then can trigger the PVC, and that as well as can trigger in the lower right-hand portion of the screen, Torsade de Pointes. In the cartoon just above where I'm circling right now, again, that's the surface manifestation of the prolonged polarization, again, the prolongation of the QT interval. This is an example not of a COVID patient, but of an initiation of a Torsade de Pointes patient of mine. This is from many years ago, and what we're looking at here is from their defibrillator. This patient was in the hospital for non-cardiac reasons, but one of the company representatives, in this case Medtronic, was asked to go check on the patient's function. And what this printout represents what happened when the representative checked the patient, because the patient arrested. And what we see seems to be, is there a lot of nothing going on in the middle of this printout here. This is what the device will tell you, is the initiation, what happens before we get to the right part of the tracing. And again, my arrow is circling around the actual electrical signals that were telemetered from the wires attached to the heart. We see this polymorphic activity. At the bottom of the screen, those letters represent markers, what we call marker channels. They give you the timing of the events of what the device thinks it's seeing. VS, ventricular sense. Over here, TS, tachysense. So it's beginning to see the rhythm, and then once it has detected it, it begins to show you the actual electrical signals. This is a blow-up of what we call the initiation, the long-short RR sequence, which which triggers the initiation. There's a long interval between R waves, long, and then followed by a QRS coming in short, and then we see FS, which means fibrillation sense, off to the races. That's the intracardiac version of this. And actually from that same patient, this is the surface that certainly we're on telemetry when this occurred. And wow, when we looked at when the pacing function of this device, this is what happened. The representative turned off the pacing, and underlying the QT interval was 740 milliseconds. Now, corrected for their heart rate here, this was still well over 600 milliseconds. And it just took that short span of time before, at the bottom of the screen, that is their actual tracing. That's what happened. That's the torsade de pointe. And that's what got initiated. So the point being of that example is certainly pacing. Pacing can be brought to bear for treating torsade de pointe. In this case, the lack of pacing allowed it to be unmasked in that patient. But I'll get to that more in a little bit. But certainly, still in talking about chloroquine and hydroxychloroquine, is there potential for bradycardia? Well, I've mentioned earlier that there's potential for affecting potassium conductance, the rapid potassium channel, but also these drugs can also affect the funny current, IF, and you'll see that in the box phase 4 at the lower right-hand part of the screen. There, circling. What does that do? That affects sodium conductance into the cell during phase 4. That's the pacemaker action potential. So as a mechanism, yes, this can, in theory, cause bradycardia, similar to other drugs that we understand. Avabradine affects the funny channel as well. But to date, I've not seen any reports of bradycardia theorized that that was the mechanism. Again, so much is evolving as more patients are seeing these drugs. We'll have to wait and see if that indeed does become the case. Otherwise, anecdotally, when we look at the long-term use of these drugs, chloroquine and hydroxychloroquine, there's a lot of data over the years. There's over 50 years worth of data. Anecdotally, the most common ECG findings of long-term use, there may be a vesicular, extremely rare that there's actual AV block mechanism associated with it. Torsade de pointe, how do we manage this? Again, this is taken from the ACLS algorithms, and we noticed there in the perspective of COVID, there's no change in anything. So if we look at the very middle of the screen, thinking about, first off, if they're sustained torsade de pointe, well, we're going to bring out the electricity. We're going to go ahead and shock them. Now, personally, from my experience in terms of seeing patients with torsade in the hospital, more frequently, it's these bursts of torsade, and they'll go back and forth between it and the underlying rhythm. So in that case, more to the point, what drugs do we, or what management strategies do we prepare? Again, no different in COVID as we would normally. Do we bring the 2-gram magnesium to bear? Again, overdrive pacing. I showed you that early example. I was able to do that, but in the scope of COVID, obviously at this point, it's not easy to drop in a temporary pacing line given PPE. That's not something that we're likely to do. Certainly in theory, could we bring external pacing pads to bear? Yes, that's possible. But certainly things that might shorten refractoriness and get the torsade to calm down. Isopropterenol will increase the heart rate. By increasing the heart rate, we shorten up refractoriness. The class 1B drugs, phenytoin, lidocaine, they will block sodium channels. They can actually enhance potassium conduction, and thereby they may have some mechanism there by shortening refractoriness and may be useful in the setting of torsade. This flowchart comes from a recent report from a group, the Northwell group out of Manhasset, New York, outside New York City. One of my old mentors, Larry Epstein, and his group wanted to clarify, given certainly I can understand the large volume of patients that they were seeing in their scope of practice outside New York City, an algorithm for managing QT prolongation. Certainly there are a lot of patients early on, and they were determining that they needed to do something in terms of management strategy, bringing drugs to bear that may prolong QT interval. And so they want to have a mechanism in place that help guide what might be the how do we manage these drugs, and how do we cut back, how do we prevent torsade. That's partly the point of this flow sheet. We look at the bottom part where I'm circling right now, heart rate greater than 80, and one of the postulations here is by considering prophylactic use of chronotropic drugs, epinephrine, norepinephrine, butamine, spironolactone, pacing, could they prevent the likelihood of initiation? And certainly that, I think they were using that out of necessity if they, again, understanding the frustrations of not having much to treat the virus with, and the patient is having problems, you want to be able to bring a drug to bear. And by using those mechanisms, as well as considering at the end of the flow sheet, giving lidocaine, again, as I mentioned, that mechanism, could they prophylactically use that as the means of preventing torsades de pointes? We deserve to understand how to measure the QT interval, because believe it or not, there's a lot of ambiguity about how to do this. And I thought this was very worthwhile talking about. And when we talk about measuring QT and determining what the corrected QT interval is, there's nearly 100 methods for calculating QT interval. And certainly I'm not going to get into that. But rather, let's just briefly talk about, how does one measure it to begin with? Frequently, in the best of worlds, if we have a 12 lead, we want to see lead 2 or lead 5, and understanding in the scope of coronavirus. We may have just one rhythm strip that reports out automatically to a telemetry monitor. Tells us what the heart rate is, what the QT interval is. But anyway, how does one measure the QT interval? So the first thing that one should find is the isoelectric segment. And that's one message here. It just reminds me, I would like those of you who are interested, get your pens out, because just in a little bit, I'm going to give you a couple links, which I think you might wish to write down, and which I think will be very informative in terms of how do we calculate QT interval in certainly various scenarios. And there's going to be an explanation of that. So I want you to take advantage of having that information and getting those links there. So have your pens ready. In any event, the first arrow that just came on the screen there, that's the PR segment. We really don't think much usually when we look at EKG about PR segment, but in this case, that helps define isoelectric segment. And so that then shows us where we take this line horizontally across, and we take this tangential line coming down the slope of the T wave as it goes towards the isoelectric, and that intersection of the tangent and the isoelectric line, that defines the endpoint of where we measure the QT interval. And I alluded to obtaining the QT interval in normal circumstances, but by all means, we want to be at the patient's bedside, apply the 12-lead EKG machine, and determine that. And again, that's obviously not feasible in where we are right now. So obviously on the right of the screen, we've got our PPE on, and that's not even including our equipment now. So just the ability to have to go in the room and bring equipment in. So again, from a risk-benefit strategy, really the risk outweigh the benefits of going in the room to do this for necessarily for that purpose. There's got to be a really good reason to be in the room and that equipment. So certainly our telemetry monitors are set to report out QT, and certainly we can generate our heart rates from that. The Mayo Clinic calculator. So here's what, again, where I'd ask you to get pens out because there's a link right below it, and I need to give kudos to my wife, who's a clinical cardiology pharmacist here at UK. She follows Dr. Michael Ackerman, who's at Mayo Clinic on Twitter. I tend to stay away from social media, so she brought this to my attention in terms of what they've now put online that will assist within COVID. How can we look at QT? How can we measure QT and measure it in multiple different fashions? And what they've done that is within the scope of their algorithm on the left of the screen. Green meaning go, the patient's good to get a potential QT increasing drug. Yellow mean caution, red means stop. And I purposely, I don't want to go through that flow sheet and tell you all the different things that are in between, certainly being very similar to what I showed you earlier on the other algorithm. But what happens is in their QT calculator, which is what comes up when you hit that button, when you hit the red button on the right of my screen, the QT calculator comes up. When you calculate the QT, it will actually put below it red, green, or yellow, give you an automatic idea of where you fit on that spectrum of safety. So once you've hit QT calculator, this is what comes up on your left. Again, QT interval can be affected by our age. Pre-pubescent, post-pubescent, that has effects. So you input your age. What is your baseline rhythm? Certainly you have your choices of, you can choose sinus rhythm, you can choose wide, and that's regardless, it can be paced. It can be a right bundle branch block, it can be a left bundle branch block. That's a choice. Atrial fibrillation, again, these are things which can cause us issues in terms of understanding how do we get to our QT interval, male versus female, what's our heart rate, and certainly in this case, I clicked on YQRS, I put in the QRS duration, and they automatically come up with a correction factor to the YQRS that then gets you, in this case, your QT interval of 440, and that's Bazit's formula. And on the right, it returns the corrected QT interval. And again, as I mentioned, there's the color spectrum. And shows that, yes, hey, this person falls within the green. This patient should be good to go. And certainly, Bazit tends to be one of the most frequent used systems. I'm not going to get into the differences in use one versus the other. Friderisha, excuse me. That seems to be more prominent in FDA trials, which is what they typically require. In any event, the four most common, Bazit, Friderisha, Hodges, Framingham, they will give you those data for whatever your heart's desire. On the right, there's Dr. Michael Ackerman on the right, being interviewed by Dr. Eric Krastowski, one of the godfathers of electrophysiology. And there's your other link, which I would ask you if you want to write down. They go through discussing the Mayo QT calculator. And it's a very informative discussion. It's not very long. I think it's maybe about 10, 15 minutes or so. And in any event, I found this very useful, and hopefully certainly, how else can we measure the QT interval? Well, what about an outpatient? The Cardia mobile device by AliveCore, it can report back a 6-lead EKG. And if anybody's not familiar with this, there's a little device, I think costs on the order of about $90 to $100. And you can link this up with your smartphone and put your fingers on this device, and you can generate an EKG. And certainly there's a reporting mechanism back to AliveCore, which has a cardiologist read the QT, and then once that's done, you can have these actually fairly good grid representations of the signal, and one can get the EKG and therefore get the QT interval. I would give a shout out to Dr. Susan Arnold. There's an initiative here with UK, called Kentucky Camostat, on our ambulatory patients coming through. We've been tested trying to enroll them in terms of Camostat as an adjunctive mechanism for potentially treating COVID. How do we follow these patients' QT intervals as outpatient? And that's a nice segue in terms of what the American College of Cardiology has commented on regarding what do we do with these patients. Now, again, I perceive this to be as a very much a work in motion because, as an outpatient, we still don't know, are we going to be using these potentially QT prolonging drugs to a certain degree? Once we get more data on efficacy, we don't know. But in the meantime, for those patients felt to be requiring these drugs, they get some recommendations. Certainly at baseline, they want your EKG, kidney. They don't want you to start with any sort of impairment in renal function and base metabolic panel, certainly magnesium levels, when at all possible. They don't want you on any other QT prolonging medications, which certainly can be difficult in the scope of it. Think about the world's population, perhaps maybe about 10% of patients may be alone on an SSRI. And certainly Mayo reported a recent look at their patient population. There's perhaps about a quarter of their patients were on some drug that increased the QT interval. In any event, they suggested that in the middle of the screen, relative contraindications certainly include a history of long QT syndrome, getting the baseline QT greater than 480, and then something I'll show you on the next one, the Tisdale score. It's a risk stratification score for QT prolongation on the next page. And then once you've had a patient, you initiate on the bottom. They suggest repeating an EKG 2 to 3 hours after day 3 dosing, and it is not dissimilar to what we do with our patients who have drugs that we prolong their QT on, potentially something like Sotalol or Tecsen. We will very frequently get that EKG a few days after their discharge from initiating of the drug. They do suggest if there's a significant increase in the QTC based upon that subsequent finding, they do give some wiggle room to the doctor. 30 to milliseconds or an absolute QTC greater than 500, or 530 to 550 if it's a YQRS. Again, they want the doctor to consider discontinuing the drug if that would be the case. Again, as I promised, this is the Tisdale score. I'm not going to spend too much time on it, but again, it's referred to in terms of different risk, different things that will play into risk. age greater than 68, female persuasion, loop diuretic, low potassium. And again, to come back and you've seen on that the algorithm, QTC greater than 450, acute MI, heart failure, other potential QT following drug sepsis. Again, maximum score being 21. And at the bottom of the screen, you're at high risk, be greater than equal to a score of 11, moderate 7 to 10, low risk less than 7. So now I'm going to switch gears and get away from necessarily treatments and QT prolongation, whether it be idiopathic, genetically QT prolongation or drug-induced. But let's talk a little bit about other genetic syndromes and potential relevance of COVID, not on them directly, but again, indirect effects of pharmaceutical management as regards these different genetic syndromes. Short QT syndrome. I'll be brutally honest, I've never seen a case of it, but as it was, I was sitting at home on home duty and reading out EKGs not 2 days ago, and I came across this EKG. And it concerned me because the corrected QT interval only came out to 328 milliseconds. And so whether or not this patient actually has short QT, that remains to be said. I picked up the phone and spoke to the cardiologist call. This patient had been seen in our ER for tachycardia, and we're making arrangements to potentially get them seen by electrophysiology and potentially genetically tested. And so we talk about what are the genetic mechanisms underlying short QT. There are defects in how we handle potassium. There's an excess of SX function in terms of very much shortened refractoriness, as well as there's also the cardiac chloride bicarbonate exchanger through gene SLC 483.42. So in this case, drugs like hydroxychloroquine and chloroquine may be beneficial because, again, if they prolong polarization, in this case, short QT is a problem with shortened repolarization. Short QT has by itself a significant risk for sudden cardiac death. Again, another recent report from my friend Larry Epstein's group at Northwell in New York City, COVID-19 infection, unmasking Brugada syndrome. This is an example of patient that showed on presentation with sinus tachycardia. One looks at the EKG, if we look at V1 and V2, you see there's an RSR prime there. There's maybe a hint, there's J point elevation. It might get your attention, but by itself, I put my nickel down and say, oh my goodness, this I'd be concerned about a Brugada pattern, a type 1 pattern, maybe not. Well, what happens with fever? Again, in the scope of a COVID infection, this patient's temperature was 102. And now we see, particularly in V1, V2, V4 elevation, V3, we see very much that type 1 pattern of Brugada come out. And why does this happen? Well, there's a loss of function sodium channel is accentuated at higher temperatures. So what's the treatment for that? Well, it's not just, again, specifically COVID. It's anything that we treat in the hospital where this may be the case. You treat the fever. You give them the antipyretic as to try and help mitigate the situation. Again, this is the EKG after the fact. Their fever was mitigated, and we can see that generously the ST changes Brugada have even gone beyond what was at their baseline when they hit the hospital. Again, one might look at that if you're reading that EKG and think nothing's going on there. What about catecholaminergic polymorphic ventricular tachycardia, CP MVT? Again, this is another mechanism that puts somebody at risk for sudden cardiac death. It's mediated by a defect in the ryanodine receptor. It disrupts calcium handling, and certainly this is provoked by exercise. Again, there's no adverse effects of hydroxychloroquine in this situation. Fever does not affect. Certainly treatments for this sort of genetic defect may include beta blockade. Again, no necessarily direct concerns about QT prolongation, but certainly, again, beta blockade with the chloroquines, could they potentially potentiate further bradycardia? Maybe. Flecainide can be brought to bear as a second-line treatment for CPMVT, and yes, flecainide does have interactions with chloroquine. And certainly as well, we have to consider ritonavir and lopinavir. Arrhythmogenic right ventricular dysplasia. On the left of the screen, I'm showing you the arrows pointing towards the classic epsilon wave. And on the right, we're showing the fatty replacement, particularly of the right ventricle. And when we talk about how we manage these sorts of patients, again, we think about using beta blockade. Um, there's some recent literature to suggest that flecainide, again, a 1C agent, might be brought to bear to treat these patients, particularly if they're non-responsive to beta blockade. And as I just mentioned in the previous slide, yes, we have to think about interactions of flecainide with some of the drugs, ritonavir, certainly the chloroquines, in terms of metabolism. Finally, regarding genetic issues, this again comes out of our friends at the Mayo Clinic, and this is being reported on in Mayo Clinic proceedings. Marked up regulation in ACE2 in hearts of patients with hypertrophic obstructive cardiomyopathy. Well, what are the implications for SARS? Again, these patients, if we look at the graph on the upper left, what is the most upregulated gene that's seen in hypertrophic cardiomyopathy? It's the ACE2 receptor. Well, again, let's go back to the beginning there where I showed you how does the virus get into the cell of the host cell? It's via ACE2. So in theory, the concern is, again, we have no data about what is the actual outcomes. Are these patients at greater risk because they have a greater number of receptors of bringing this virus in and particularly having more significant cardiac manifestations? Stay tuned. We may hear more. I'll be honest, I had a patient I had on telehealth yesterday with hypertrophic cardiomyopathy. Fortunately, she is many hours away. There's not been any penetrance of the virus into her area. At the same time, I was very much cautioned her to follow her distancing protocols and hand washing because of this possibility. Whether or not it's fear unfounded versus is it real, again, remains to be seen. So now let me transition to the later part of the talk in terms of ethical, if you will, dilemmas. And I've titled this slide COVID-19 quote versus ... You can fill in the blank. And again, this is meant to say that this is not specific to me, what I do in electrophysiology. I think this applies to any of us who take care of our patients. We're all feeling the burden of, as we focused on treating COVID, it's not one versus the other. It's rather, how do we take care of all of our patients? It's not versus. But certainly there are concerns about some of our patients having issues that may be neglected. And I had the opportunity 1 week ago, Dr. Newman was walking out. I found him in the hallway and I grabbed his ear. We discussed this briefly. I mentioned my concern about are we ultimately causing harm? And I know Dr. Newman shares this and certainly has mentioned that he and other leadership role players are trying to drill down and figure out and make sure, is there a way to quantify, are there other patient groups that we are maybe not putting as much attention as we need to? Do we need to change things? Just anecdotally, in my conversation with cath lab today, we seem to be seeing a spike up in, at least not from the EP perspective, but from the interventional perspective, patients coming to the cath lab. Does this mean anything? I don't know. Is it potentially some of these patients are grit and bearing things that we otherwise would normally be taken care of if we didn't have to worry about them coming to the hospital? Again, I'm trying to get my patients to appreciate that hopefully in the scope of where we are now, hopefully we'd be safer coming to the hospital rather and not getting, as opposed to getting out in the community, knowing what we do in terms of using our PPE and following hand washing precautionary measures. In the scope of what I do, what I discussed as we're trying to think about breaking out come Monday, doing more procedures between myself and my partner, Dr. Ellison, my EP coordinator. Independently, I queried, what is our most growing concern about patients that maybe perhaps we've been putting off a bit too long, and it's the patients that we're concerned about sudden cardiac arrest, and potentially the primary prevention ICD population. So this graph shows us, what is the annual incidence of sudden cardiac death, and easily that toward 350,000 cases a year towards some of these other conditions. Again, I don't try to minimize the risk of other conditions, but again, just showing you sort of these comparisons. So within the scope of sudden cardiac death, arrhythmia is very much on the minds. the tachyarrhythmias play a predominant role in terms of sudden death and patients needing primary prevention ICDs. This is what we unanimously within EP service determined that we need to start getting these patients in the scene. Certainly, congestive heart failure is also a concern for ours. And yes, there are devices that we can bring to bear. On the right, we see a heart, and that shows us the a biventricular device. There's the 3 wires. There's the LV lead. There's the RV lead and the atrial lead. But on the left, I also want to let you appreciate that within the scope of the prevalence of heart failure worldwide, when we look at class 2 and class 3, the predominance of patients with low ejection fraction heart failure actually have a narrow QRS. So I can't bring that biventricular device to bear for them. No, there's no evidence that shows that's beneficial. But something that we've recently gotten on formulary here that has potential for helping out patients with narrow QRS heart failure, something called CCM, cardiac contractile modulation. This is something that we're sort of itching to break out to these patients. We have a large population of patients who are on ambulatory IV milrinone who have narrow QRS pretty young. That could we provide such a device that might help them? And so what I'm showing you on the screen, CCM, cardiac contractile modulation, it's a separate pacemaker device that actually doesn't stimulate the heart to contract. And we see on the right is an X-ray of the device. It's on the right chest. The patient has a pre-existing defibrillator before the implant on the left. And so there is your pacing device. It has the wires that go to the heart. And what this does, it's got a pacing function that stimulates the right ventricle. Now go to the cartoon on the left. During phase 2 of the action potential. So what happens during phase 2? There's calcium influx. And one of the issues with heart failure is that there are genetic mechanisms that, or gene mechanisms that get programmed off or on that may cause there to be a deficit of the ability of calcium to affect coupling of actin and myosin to help out contraction. This device, on a global effect from stimulating the heart from very discrete locations where you have the blue arrows on the right, seems to be able to affect globally influx of calcium and affect certainly things as Minnesota quality of life scores, 6-minute hall walk test, et cetera. So these are things, again, which we're itching to help out our patients with. Atrial fibrillation, I spent a lot of my life in taking care of atrial fibrillation. Certainly there have been a few patients of ablated their AFib even during this. But what we're looking at here is a patient from upper right-hand corner 2 days ago. This is from their implanted loop recorder, and in the EKG, we're seeing there's rapid AFib, and then we see, there's a pause. And there's a 6 second pause. And this patient passed out. And I was on the phone with telehealth with this patient, and she was on flecainide beta blocker. And I said, oh gosh, again, the flecainide beta blocker contribute to sinus node pauses post tachycardia and to provoking this. At the same time, I'm telling her to decrease her flecainide. I'm trying to keep her on her feet, telling her not to drive a car, seeing if we can't keep her home and try to get her in sooner or later so that I can ablate the AFib and then not have these post tachycardia pauses because I mitigated the AFib. Again, I'm trying to keep this patient from needing a pacemaker or early admission to the hospital. As well, regarding just loop recorders in general, another population of patients that we identified with the EP that we thought were concerned about not getting done sooner there. Loop recorder implants for cryptogenic stroke. We use these devices to try and determine is there been an AFib cause of the unclear source of felt to be thromboembolic source of AFib. So in summary, COVID-19 has exhibiting cardiac effects, certainly direct, and I think you appreciate it, indirect from comorbid conditions or what we're doing to the patient. Again, how we manage a lot of the situations, whether it be arrhythmia, brady, or tachy, it's not seemingly different from what we already know. The key is pharmaceutical vigilance. This is going to be a rapidly evolving management strategy. What drugs work, what drugs may not work. Are we going to have to learn how to handle these patients as outpatient? Because yes, certain drug strategies are beneficial. Who knows? Again, it's a very rapidly evolving target, and certainly managing non-COVID issues is challenging with these set. So again, I appreciate your attention. Again, I hope I was able to distill this information down in terms of some very lucid points and teaching points in learning. And I will leave it at that for back to Northrop and be happy to entertain any questions.
I have a few questions here already, and feel free to type more in as we go through them. Do patients with AFib have any particular or unique risks associated with COVID?
Well, directly, no, but certainly, I think part of that answer depends on what are they being treated with. Certainly, from the standpoint, if you get COVID and you have AFib and you are on amiodarone, you're on Ticastin, you're on Sotalol, you're on a 1C agent, it's like a propafenone. I think more so, these issues will come into play. How do we medically manage the patient? Now, again, as we go forward and not knowing from these observational data, quote, arrhythmia occurring within the scope of patients with COVID and making them more at risk for in-hospital death, is that possible? Maybe. There's so much we need to learn more in that regard.
How accurate is the 5-lead telemetry derived continuous QTC monitoring, assuming you obtain an initial EKG to compare as baseline?
Well, certainly we think it's accurate enough that, again, we want to apply it as outpatient to our study. And again, in my discussions with Dr. Smythe, Dr. Arnold, with regards to how we want to apply sort of a mobile signals besides any in-house telemetry signals, we think they should be accurate enough that we can make appropriate clinical decisions on how to manage patients.
Does COVID-19 promote coronary thrombosis?
Earlier, with the earlier screens, certainly we talked about there being microvascular defects of the infection. Certainly, there are increased risks of thrombosis. Again, you're getting the heart electrician and a little bit out of their comfort, but certainly from my peripheral listenings to people who are more involved, certainly like Dr. Smythe and understanding, yes, I think there are mechanisms which where there may be plaque disruption or microvascular issues, or I know if in situ thrombosis formation. I think there's certainly still a lot we don't know. Think about that. Partly how do we answer that question? Could these patients get cardiac caths? Certainly, again, we're trying to minimize how do we get these patients to the hospital? Do they need to be in the cath lab? Do they need in the EP lab? So as much as we'd like to get some of these answers, maybe some gold standards of what's going on in the coronary arteries, that becomes much more difficult within that scope.
And while it won't be a cardiac discussion, next week, Dr. Ramalal will be covering the hematology aspect. So I think that'll be a good person to also
Excellent,
ask
yes.
about thrombosis. So we have another one. Please discuss the cardiomyopathy in patients with COVID-19.
Cardiomyopathy. Well, go back to the beginning, if you will, and show about, again, the myocarditis, certainly direct effects on the myocardium in terms of causing dysfunction. Again, the inflammatory responses, again, acidosis, things that have negative inotropic effects. Again, it's a perfect storm of a bunch of things that, when they're applied in tandem, could all of these play a role. Again, as we're, again, is there microvascular damage? Is there actual thrombosis occurring? Again, are we otherwise picking off different parts of the myocardium? And all of these things, the intravascular or extravascular to the myocardium, contributing to cardiomyopathy. I think all of these things, I think, could potentially play a role. But certainly, right now, I don't know if there was any way to discern, weight of one versus another.
So the next comment was excellent overview. Are you able to comment on the incidence of arrhythmias and other cardiac disorders associated with previous SARS and MERS experiences?
You know what? I'll comment when I discussed those other genetic conditions as regards short QT, ARVD, catecholamic VT. That actually I drew that from the paper that's actually in press and heart rhythm right now, where sort of these recommendations, they primarily leading up to COVID, they talk about MERS, they talk about SARS. That's where they draw from a lot of their experience in terms of ultimately the comments that they made in saying that yes, this experience we can apply to COVID-19.
All right. That was the last question I have. Thank you very much. It was an excellent review. And I will go ahead and end the meeting. We're already 10 minutes past the hour, so I think folks will really engage.
Dr. North, thank you for all. Appreciate your time and letting me go over. You all, again, stay safe. Thank you so much.